Hello, Mr. Robert. Could you introduce yourself a little bit? Who you are and how did you came here?
My name is Robert Leech. I am the head of the emergency department in St. John's Hospital and also the head of the pre-hospital team. St. John's Hospital is located in Brussels in Belgium. I am here as vice president of the European Society of Emergency Medicine.
Many people don't know Lithuania as it is such a tiny country, but you found some time to visit us. How did you find it and how did you know about it? What brought you here?
Well, as I said in my talk this morning, this is a very historic medical congress for Lithuania for numerous reasons, and it is the role of USAM to be present. Lithuania and the Lithuanian society are members of USAM, and so it's natural that USAM is here.
You already seen some of the major people in emergency medicine in Lithuania. And emergency medicine, as residents and as physicians, we all are starting. We are baby steps in Lithuania. What could you wish us for to be successful as it is in America or in major European countries?
Well, you know, actually, Dr. T, as she prefers to be called, Professor Tintinelli, was able to describe actually quite a similar situation in the United States as in Europe. And so to answer your question, of course, I personally and USAM wishes the best of luck on all of your professional careers here in Lithuania or elsewhere within the European Union. However, I think what's very important, and I closed my speech with this, is that today, because of the importance of emergency medicine, it is not enough just to practice good emergency medicine. We must be active actors in the evolution of our specialty.
How do you personally motivate your residents in your hospital? Do you see what I mean?
Yes, I understand. It's easy and it's difficult at the same time. I very much enjoy what I do, and I hope that that enjoyment by example is transmitted to my residents. I think that it's not always very easy on the other side to stimulate, to promote a specialty that sometimes the residents are there, they have chosen it, but they can have doubts. Is this the right way to go? Do I want to be working nights and weekends for the rest of my life? And so it's quite a challenging profession. And I think what I try to do is I try to be there for my residents. And I've had, unfortunately, just last week, one of my residents who decided to stop. And she not only decided to stop, she decided to stop medicine, and for personal reasons. And I said to her, I said, if you ever want to talk, or if you ever just want to talk out loud to yourself with someone, my door is open, please come. So I think that yes, of course, maybe you were waiting for me to say I have mini symposiums twice a week, which I do, and all of this sort of thing, but that's not enough. You know, it's not enough. We need in emergency medicine people with character that will be able to, as I said, actively take part in the future of the profession. And it's not easy. And all of our colleagues in the other professions are not necessarily our allies. That doesn't mean they're there. They are our enemies, but they're not necessarily our allies.
And the last question, how do you stay healthy besides emergency medicine?
It's very interesting. In Athens, I spoke about work-life balance. And I said that I didn't like that term because that means that when you work, you don't live, and that when you're living, you're not at all working. And I think that whereas there may be a bit of truth in that, I think at the same time, I live when I work. And when I am living, I think of work. And I don't see that as a problem. So I try to have a certain balance with that, and sports and healthy lifestyle, and what else can one say?
Thank you very much.
Not at all, my pleasure.
It's a real pleasure to having you here. What is your name and where are you from?
Thank you. My name is G.Gaddis, and I'm an emergency physician. I currently work at the Washington University in St. Louis School of Medicine, and I am now in my 29th year of emergency medicine practice, having completed residency in 1989. So that's probably older than some of you are.
Yeah. And how did you know about little country Lithuania and this emergency medicine congress here today?
There's a couple of connections I have. One is that three of the, some of your more senior emergency physicians went to Dallas and participated in the emergency medicine basic research skills course. And I've been a statistical instructor for the EMBERS, it's called EMBERS course, since 2009. And actually I recently became the director of the EMBERS program, chairman. But anyway, I knew three of them through that. And then the other connection is through Poland. I believe Dinas and some of the other leaders are aware of how the Polish Society became established, and they have some connections. And we've become, we being most of the emergency physicians from the United States who are here, have some connection with the Poles, and I think that that may have made a little bit of a ready-made group that your society's leadership might have been familiar with, so they would invite somebody that would be likely to come.
Is there any one thing you could change in emergency medicine field?
That's a really tough question.
I know.
I actually think that there's a number of things I would change, and some of them are specific to the specialty and some of them are specific to the United States. So I won't go into the United States things. But I think the hardest thing about emergency medicine in the long run is circadian disruption. We are wired as human beings. Some people are morning people and some people are evening people, but most of us aren't really left on our own. Most of us wouldn't stay up all night. And as one gets older, I think that was the hardest thing about being an emergency physician, is the different times of day. You know, in the United States, when we changed from regular time to daylight saving time and moved the clock forward, we can actually measure a slight increase in the number of road traffic deaths and road traffic crashes. And all the commentary in the news is about how difficult it is on people to change their clock by 1 hour. And as you know, those of us in emergency medicine are thinking, we have no sympathy for this argument because we're always like on a continual trans-world flight. So that's the hardest thing. It's not the not knowing what's coming in the door. And it's not even the disrespect from the older physicians that don't understand why emergency medicine is so important. But if I were to change one other thing, there's something that's been true in every country where emergency medicine has become a specialty. And that is that you can conceive of what we do as a bridge. So imagine a very deep gorge. And in this thought model, one side of the gorge is emergency medical services. Most every country in the world that's a second world or first world country has ambulance services and paramedics. The other side of the gorge is the hospital with its intensive care units and inpatient units. Most every country in the world has hospitals. Some have higher capacity than others, but they have hospitals. But where every country has struggled, including mine, is building that bridge across the gorge between the pre-hospital arena and the in-hospital arena with those of us that do what we do. And what we do is we figure out how to, we're taught how to stabilize the sickest patients. For lack of a better word to describe it, we figure out what bin they go into. You know, do they go into the intensive care unit bin? Do they go into the general ward bin? Do they go into a telemetry but not intensive care unit bin? Do they go into the operating room bin? Or do they go into treat and release bin? Because that's what we do. And every country in the world has older physicians that just don't understand what we do and don't value what we do. It's sort of like, I think it was Max Planck said that sometimes science advances one death at a time. And the people that are so against us, eventually they retire and they get out of the way. And you younger folks and your peers probably understand a lot better than the middle-aged and older folks why we're so important to a mature health system. And I'm going to tell you one other story since you're nodding. Okay. Emergency medicine actually is research born more than people give it credit for. And to prove that, I'm going to tell you a story about my grandfather's heart attack. My grandfather was born in 1908, and he had his first myocardial infarction in 1963 at the age of 55, and he was in the United States. So the first question is, if he had to call somebody to take him to the hospital and he couldn't drive himself or his wife couldn't drive him, how would he get to the hospital? And the answer was there were no modern ambulance systems back then. He would have called a phone number and maybe they would have sent, that what they probably would have sent was a hearse, a funeral home vehicle, because the hearse for carrying bodies to the cemetery was perfectly shaped to carry bodies to the hospital. And the cynical person could say it was just a form of self-referral because emergency medicine care wasn't that good then. So that's the first part, is how do you get to the hospital? The second thing is what happens once you get there. The first cardiac bypass surgeries that were done were all done as elective procedures, not during an MI. And those started in the late 1960s. And so by that, I was born in 1957. So I was in junior high. I was 12 or 13 years old before cardiac bypass became a regular thing that anybody did, even at referral centers like the Cleveland Clinic and the Mayo Clinic. And to be able to have cardiac surgery and bypass surgery and valve surgery in a town of 150 or 200,000 people, that didn't happen until maybe the early 1990s. So the availability of bypass, it just wasn't there then. And of course, angioplasty came along even later. It wasn't until the early 1980s that angioplasty even began to diffuse out of the centers where it was developed. And actually, the very first angioplasty in the history of the world that was done during an acute MI was done in Kansas City, Missouri, where I used to work until 2 years ago, by a cardiologist named Jeffrey Hartzler, who was the first man brave enough to do angioplasty during an MI. So we didn't have angioplasty, we didn't have time to balloon, we didn't really have time to needle either, because there were reports about making TPA as a treatment for acute myocardial infarction as early as 1979. But that was before we really had recombinant DNA technology that would enable the production, the mass production and industrial scale production of TPA. And it wasn't until the late 1980s, early 1990s, where we really began to use TPA a lot for myocardial infarction. And of course, so going back to my grandpa, so it's 1963. Oh, by the way, were we doing CPR for in-hospital cardiac arrest then? No. There were some places doing open cardiac massage, and there were maybe a few places starting to do CPR. But if you had a cardiac arrest in the hospital, you're dead. And the treatment for acute MI in 1963 was beta blockers, aspirin, bed rest, and just hope you don't get a pulmonary embolism lying in bed for 2 weeks. It's all true. And so now take us from 1963 to 2018, 55 years later. We have cath labs, we have angioplasty, we have anticoagulant medication. Oh, I guess they might have used heparin back then too. But we have so many more tools. The tools that are important for caring for a myocardial infarction patient that we have to use and intelligently understand about didn't even exist when the people who were older doctors when I was in residency training were in residency training themselves. And so, they would say about emergency medicine, why do you exist? You can't say an organ system that's yours. You're not the pulmonologist that has the lungs. You're not the cardiologist that has the heart. Why do you exist? And the why we exist is predominantly for those time-critical illnesses. They are our primary customers. But the tools we have for those primary customer illnesses didn't exist 50 years ago, as I've illustrated in the case of MI. I'll make another example just to illustrate my point. You've all used non-invasive ventilation. You know of continuous positive airway pressure and BiPAP. Okay. When I was out of residency in 1989, we did not yet have those tools. We intubated many, many more patients than we do now. I'm quite sure there are patients who died after an ICU stay because of pulmonary barotrauma or whatever, or were difficult to wean because they were on a ventilator with an endotracheal tube, that now we intercept them earlier, we do non-invasive airway management, we save them from being intubated, we decrease their number of days in the ICU, and so it goes. We are so research dependent because the things we do for our most critically ill patients didn't exist 10, 20, 25 years ago. And that's why I think Dr. Mulligan was right when he talked about emergency medicine being a paradigm shift, but the paradigm shift had been enabled by a large body of research that can help mobilize us to take care of the critically ill patient in ways that didn't even exist a generation or two ago.
Maybe you remember your first shift when you were an ER resident?
Yes.
Your first shift, can you share with us your feelings, what you were thinking?
Well, my first shift was at a place called Miami Valley Hospital in Dayton, Ohio, in the United States, because that's where I had my residency. And we had an orientation, and we had attendings in the department, and we pretty much knew that whenever we had a question, there was always somebody else to ask. They didn't just turn us loose unsupervised when we were in our first weeks. So it was a humbling experience because you know what you don't, you're starting to learn what you don't know. But also it was a good experience to actually be able to use the skills that you'd been taught all along. And I don't know how it is in Lithuania compared to the United States, but when I was in medical school, students got to do a lot more procedures than they do now. Like by the time I started residency, I'd put in at least 6 or 8 central lines, I'd intubated numerous patients, I'd probably done 50 blood gases, and so it goes. Whereas nowadays, with the way training is in the States at least, you're not as likely to get that number of procedures. I'm interested. The bottom line is, the first shift I ever did, it was gratifying to use some of the skills I'd been learning, but humbling to realize how much I still didn't know.
And maybe you can share, maybe you have some personal secret, how to stay fit or stay sane, you know, during the crazy shifts and everything.
Okay, well, I actually think fitness of some sort is really essential for me to perform at top level. And that's just me, but I'm 60, and I just ran a half marathon a week and a half ago, and I'm an active cyclist, and I don't lift weights to bulk up, but to me, being fit is important for an emergency physician because we have a physically taxing job. We have to be able to spend a lot of energy when we're seeing patients, and I don't think you can see patients effectively if you're thinking about how tired you are. So that's one thing. And then the good thing about emergency medicine is it does give you some outside time to cultivate outside interests. The bad thing is some people just don't understand how busy you are when you're clinically on duty. You know, the idea that you don't even have time to, you don't have lunch hour, you don't have lunch 30 minutes, you got lunch 90 seconds. You know, that's sort of foreign to most people.
Also, emergency medicine is only starting its first steps here in Lithuania. Maybe you have some advices for our new emergency medicine physicians. They're going to be in few months, and maybe to the future residents here in Lithuania.
Well, I have a couple of thoughts on what might help things go better. And one of them is just to exert your competence and win people over by your ability, and know what you know and what you don't know, and know the difference, and don't be afraid to ask questions. If you don't know, don't bluff. You know, you're going to hurt somebody if you try to bluff. Be an important member of the care team. The other thing is, sometimes people like to go into emergency medicine, at least in the States, because they don't want to be in a committee and they don't want to be around when the administrators are around. And I think that's a really bad attitude. I really think that as an emergency physician, you have to make yourself a member of the community you're joining when you join a hospital staff. Because when you call somebody up for that difficult to manage patient, you know, the person you're calling, you're giving them extra work. And I don't know how physician reimbursement is here in Lithuania, but there are times when you are giving your peer, who's the inpatient doctor, a difficult and perhaps even disagreeable assignment. And when you meet people who are part of the hospital care team and you work on them with a committee or you just have, one of the things we did at the hospital I came from, we met with the hospitalists, the internists. We would go like twice a year, have some social function, and just get to know each other and become a member of your community. That's a very important thing, because if you just go up and see patients and go home, it's more of a job than a career. But I think that medicine deserves to be treated as a career and not just a job. And so, you may not be getting paid for committee work, but I think it's a crucial part of your formation.
Thank you very much.
You're welcome. So, thanks for the opportunity to express my thoughts.